Welcome to this session on glaucoma, focusing specifically on the surgical management of the disease. In this first part of Chapter 13.1, we'll explore the principles, techniques, and decision-making frameworks that guide how we approach surgical therapy. As we move through the material, the goal is to build a strong understanding of why certain procedures are chosen, how they work, and where they fit within the broader care of patients with glaucoma. As we get started, it's helpful to outline the major themes that will guide the rest of this discussion. One of the foundational ideas is that laser trabeculoplasty continues to be a reliable option, whether used as a primary therapy or as an adjunct, particularly for patients with open-angle disease or ocular hypertension. At the same time, the surgical landscape for glaucoma has expanded dramatically. Over the past several years, we've moved from a very limited set of operations to a broad spectrum of procedures that allow us to tailor each intervention to the patient's anatomy, disease severity, and risk profile. Even with all these new developments, the core procedures, trabeculectomy and tube shunts, still play a central role in managing moderate to advanced disease. They remain the benchmarks against which many newer procedures are measured. Finally, cataract surgery has become an important tool in managing angle closure disease. By deepening the anterior chamber and altering the anatomy of the angle, lens extraction can have a meaningful effect on intraocular pressure and disease control. Now that we've outlined the major themes, we can focus on why we operate. All glaucoma surgery aims to lower pressure by either reducing outflow resistance or decreasing aqueous production. Some procedures enhance the eye's natural drainage system, while others create entirely new routes for fluid to exit. We consider surgery when glaucoma progresses despite maximal medical therapy, or when the patient is at high risk of further loss. It's also appropriate when medications are poorly tolerated, used inconsistently, or aren't practical for long-term management. As we shift into how surgery is selected, the overall strategy depends heavily on the type of glaucoma. In primary congenital disease, incisional surgery is the first-line approach because medications are rarely effective enough on their own. For most other glaucomas, we start with medications or laser, reserving incisional procedures for cases where safer options aren't sufficient. That caution is deliberate because traditional surgery carries real risks, things like infection, hypotony, or cataract formation. The goal is always to balance the need for pressure control with the safest effective intervention. As we look at the evidence guiding when to operate, early trabeculectomy studies initially suggested a meaningful advantage. Patients tended to achieve better pressure control and required fewer office visits. The SIGS trial added more nuance. It showed that starting with surgery does produce lower pressures than starting with medications, but that difference didn't translate into better visual field outcomes overall. Progression rates were low in both groups, yet certain subpopulations behaved differently. Patients who already had advanced baseline field loss actually fared better when surgery was used up front, with slower progression over time. In contrast, patients with diabetes tended to lose more field when surgery was their initial treatment. Those findings shape current practice. Most clinicians still delay incisional surgery for open-angle glaucoma until medications and laser therapy fail, but earlier intervention is considered when someone walks in with advanced visual field damage. It's a balance between preventing further loss and exposing the patient to the risks we discussed on the previous slide. Building on that discussion of when to operate, it's important to think about what we choose when surgery becomes necessary. Traditional operations like trabeculectomy and tube shunts remain the most powerful tools we have for lowering pressure. They produce large and reliable reductions in IOP, but that benefit comes with a higher risk profile, including hypotony, infection, and longer-term complications. MIGS represents a very different philosophy. These procedures intentionally trade some degree of efficacy for a much safer post-operative course. Rather than creating a new subconjunctival drainage pathway, MIGS techniques typically work through the eye's existing physiologic outflow system. That distinction explains why they're attractive earlier in the disease course or in patients where the risks of a full filtering surgery outweigh the potential gains. As we start comparing specific procedures, it becomes clear that choosing the right operation is rarely a simple algorithm. Each option comes with its own indications, contraindications, and anatomic requirements, and all of that has to be balanced against the surgeon's own experience and comfort level. The rapid expansion of MIGS devices and techniques has added even more possibilities, which is great for individualized care, but also means the landscape is constantly evolving. Because true head-to-head comparative studies are limited, the final decision often comes down to a reasoned judgment call tailored to the patient sitting in front of you. Now that we've talked about how surgeons select a procedure, it helps to zoom out and look at the major mechanisms we rely on to lower intraocular pressure. Almost every operation in glaucoma surgery fits into one of two broad strategies, either decreasing inflow or increasing outflow. Decreasing inflow is achieved through cyclodestructive procedures, which target the ciliary body to reduce aqueous production. These can be external cyclophotocoagulation, performed in discrete applications or in a continuous fashion, or endocyclophotocoagulation, which is done internally. Most of the operations we use, however, work by increasing outflow. Within that category, there are several pathways. Some procedures divert aqueous into the subconjunctival space, such as trabeculectomy, traditional tube shunts, the X-breast device, short aqueous stents like Zen or PreserFlow, or the non-penetrating surgeries like deep sclerotomy. Another major group targets outflow through Schlemm canal. That includes non-incisional options like laser trabeculoplasty, as well as procedures that physically disrupt the trabecular meshwork, things like goniotomy, trabeculotomy, and the trabectome. Others bypass the meshwork with devices such as the iStent or the Hydrus. And some approaches focus on expanding or supporting the canal, which is also where Hydrus fits. Finally, canalsoplasty, whether performed externally or internally, enhances circumferential outflow by tensioning or viscodilating the canal. As we move forward, we'll break down many of these techniques in more detail, focusing on how they're performed and where each one fits in clinical practice. As we move into specific procedures, the first major category is laser trabeculoplasty. This approach targets the trabecular meshwork directly by applying laser energy in discrete treatment spots, usually over 180 to 360 degrees. The goal here is straightforward. We're trying to enhance aqueous outflow through the conventional pathway, which in turn lowers intraocular pressure. There are several different laser systems that can achieve this. Selective laser trabeculoplasty, or SLT, is the most commonly used today because of its favorable safety profile and its ability to be repeated. Argon laser trabeculoplasty, or ALT, is the older thermal technique. And more recently, micropulse systems, such as those produced by Iridex, deliver laser energy in short bursts to minimize collateral tissue effects. Laser trabeculoplasty plays a key role because it offers a non-incisional way to improve outflow before committing a patient to surgery, and it often delays or reduces the need for additional therapies. Laser trabeculoplasty was once thought to work by creating holes in the trabecular meshwork, bypassing resistance. That idea was later disproven, and the true mechanism is still not fully understood. Different laser types likely act through different pathways. With argon laser trabeculoplasty, thermal effects can shrink and stretch collagen, widening adjacent trabecular spaces and improving outflow. Newer modalities like SLT and micropulse don't produce meaningful thermal damage, suggesting non-thermal and cellular mechanisms instead. Across laser types, several responses have been proposed. Increased trabecular cell division, cytokine-driven remodeling of the extracellular matrix or Schlemm canal endothelium, recruitment of monocytes and macrophages, and enhanced phagocytic activity within the meshwork. Overall, laser trabeculoplasty appears to improve outflow by triggering a coordinated biological response rather than by altering anatomy alone. Building on that discussion of how laser trabeculoplasty works, the next question is when we should use it. LTP is effective at lowering pressure in open-angle glaucoma and in ocular hypertension, and its role has shifted over time. It was traditionally reserved for patients who had already failed maximal medical therapy, but evidence now shows it performs better when introduced earlier in the disease course. Because it offers meaningful pressure reduction without the burden of daily drops, many clinicians view it as a first-line option. That makes it especially valuable for patients who struggle to instill drops, those with poor adherence, or patients whose ocular surface disease worsens with topical medications. In these groups, laser can offer both therapeutic and quality-of-life advantages. As useful as laser trabeculoplasty can be, it does have clear limitations. The angle must be open for the laser to work, so any eye with significant narrowing or closure isn't a candidate. In patients with very advanced glaucoma and markedly elevated pressure, other treatments are usually preferred because the effect of LTP may be too modest for the level of disease. We generally avoid using it in anterior uveitis, since inflammation can worsen and peripheral anterior synechia can form. The rare exception is a steroid-driven pressure rise in an otherwise quiet eye where LTP may still offer benefit. There are also situations where LTP simply doesn't work, such as eye syndrome, neovascular glaucoma, or when extensive synechia already block access to the trabecular meshwork. When the patient is an appropriate candidate, the technique itself is fairly standardized. We usually begin with a topical hypotensive agent, such as brimonidine or apraclonidine, to reduce the chance of a post-operative pressure spike. A laser gonio lens is then placed with methylcellulose to obtain a clear view of the TM. A key step is identifying the Schwalbe line correctly so it isn't mistaken for pigmented trabecular meshwork. This ensures the laser is applied exactly where it should be. And in eyes with a heavily pigmented meshwork, we deliberately lower the energy settings, since these eyes are more prone to abrupt IOP elevations after treatment. Now that we've covered the basic technique, it's helpful to compare the typical settings for the main laser systems. Selective laser trabeculoplasty uses very low energy pulses in the 0.4 to 1 millijoule range, with a large fixed spot size and a nanosecond pulse duration. Because of the low energy and short exposure, it can safely treat up to 360 degrees in a single session. Argon laser trabeculoplasty, in contrast, uses much smaller spot sizes and longer pulse durations, typically treating only 180 degrees per session. The higher thermal load explains the narrower treatment area. Micropulse systems fall somewhere in between. They use a micropulse delivery pattern that limits heat buildup while allowing treatment over a full 360 degrees when needed. The illustration below shows how these laser spots are applied relative to the Schwalbe line, the trabecular pigment band, and the scleral spur. SLT and ALT target the same anatomic region, but their energy profiles and tissue effects are fundamentally different. Moving into argon laser trabeculoplasty specifically, the key principle is precise beam placement. The burns are aimed right at the junction between the anterior non-pigmented trabecular meshwork and the more posterior pigmented portion. Shifting too far posteriorly increases the risk of focal peripheral anterior synechia, so position really matters. Power is adjusted until you see either a mild blanching or a very small bubble. Anything larger means the energy is too high and the power should be reduced before continuing. A typical session involves 40 to 50 spots over 180 degrees of meshwork. Most clinicians treat only half the angle during the first session. That strategy helps minimize post-operative IOP spikes and preserves the option to retreat the remaining half of the angle later if needed. Shifting from ALT to selective laser trabeculoplasty, the approach becomes far more targeted. SLT acts on intracellular melanin within trabecular meshwork cells, which allows it to produce a biologic response without the thermal damage seen with argon laser treatments. It uses a frequency-doubled 532 nanometer Q-switched ND-YAG laser with a 400-micron spot and a very short pulse duration. Energy is titrated until you see cavitation bubbles, or set just below that threshold, depending on the surgeon's preference. Treatment can be applied over 180 to 360 degrees, but most surgeons now treat the full angle in a single session. Over a complete 360 degrees, the typical application ranges from 80 to 120 spots. After discussing SLT, micropulse laser trabeculoplasty builds on the same wavelength but delivers energy in a completely different way. Instead of a single, short pulse, MLT uses a thermal laser with a much longer application time. The key feature is its 15% duty cycle, meaning the laser is active only 15% of the time and off for the remaining 85% in a repeating sinusoidal pattern. Those brief cooling intervals are what make MLT gentler. They limit thermal injury to the trabecular meshwork and surrounding tissue, which is why the procedure is often described as subthreshold. Treatment is typically applied over the full angle, with about 120 to 140 confluent spots delivered across 360 degrees. Postoperative care varies slightly depending on the laser used. After ALT, most patients are more comfortable if they use a short course of topical steroids or an NSAID. With SLT, at least one randomized trial suggests that these same medications may actually enhance the IOP lowering effect, though this isn't universally practiced. For MLT, there's no evidence-based regimen, and nothing is specifically required, since the treatment is designed to be subthreshold and minimally inflammatory. Regardless of the laser type, the typical follow-up interval is about 4 to 6 weeks, which is when we can reliably assess the IOP response and decide whether further treatment is needed. When we talk about complications after laser trabeculoplasty, the most frequent issues are fairly mild: inflammation, transient IOP spikes, and some discomfort. Spikes are most common in eyes with advanced disease, and they usually appear within the first hour, which is why early post-laser checks matter. Several medications can blunt these spikes. Apraclonidine or brimonidine are the most effective, but beta blockers, pilocarpine, hyperosmotics, and oral carbonic anhydrase inhibitors are also options. Prolonged refractory IOP elevation is rare, but when it does occur, some patients ultimately require incisional surgery. Treating only 180 degrees instead of 360 can also lower spike risk, and this is particularly helpful with ALT. With ALT specifically, posteriorly placed burns can lead to peripheral anterior synechia, so careful positioning is critical. Other complications are uncommon, but include low-grade anterior segment inflammation, hyphema, herpes simplex reactivation, and, in rare cases, keratitis leading to irregular astigmatism. When we look at how effective laser trabeculoplasty is, SLT and ALT perform remarkably similarly in terms of IOP reduction. Across studies, roughly 80% of patients with uncontrolled open-angle glaucoma show a meaningful pressure response, and that benefit typically lasts at least 6 months. Among those who respond initially, about half maintain the effect for 3 to 5 years, and close to a third still have a benefit 10 years out. The response tends to be stronger in older individuals, in primary open-angle glaucoma, and in pseudoexfoliation glaucoma, where the trabecular meshwork tends to be more reactive to laser treatment. Repeatability is always a consideration. The effect does diminish with subsequent treatments, but SLT remains repeatable, even in areas that previously received ALT. In contrast, repeating ALT is less effective and carries more risk, so most surgeons avoid multiple ALT sessions.
Building on the discussion of efficacy, two major clinical trials help anchor how laser trabeculoplasty performs in real-world management. The glaucoma laser trial looked at newly diagnosed primary open-angle glaucoma and compared ALT with timolol. ALT performed just as well as medication in lowering pressure, preventing visual field loss, and slowing cup disc progression. The design had an important limitation. One eye received ALT and the fellow eye received timolol, so a contralateral effect may have diluted the true difference between treatments. And despite the strong early response, many ALT-treated eyes eventually needed medications during follow-up. More recently, the LIGHT trial compared SLT with medications for the initial management of ocular hypertension and open-angle glaucoma. At 3 years, pressure control was essentially the same between the groups, but SLT stood out as more cost-effective. Patients in the SLT arm also reported better quality of life scores, which has been one of the strongest arguments for considering SLT as a true first-line therapy. Transitioning from trabeculoplasty, cyclodestructive procedures take a very different approach. Instead of improving outflow, they work by reducing aqueous production. The laser targets the non-pigmented ciliary epithelium, damaging or destroying it to decrease fluid formation. Depending on the technique, there may also be some effect on the ciliary muscle. When that happens, uveoscleral outflow can increase slightly, adding a secondary mechanism of pressure reduction. Cyclodestruction can be delivered internally or externally. Internal approaches, such as endoscopic treatment, allow very precise targeting with less collateral injury, but they require entering the eye and therefore carry higher procedural risks. External treatment avoids interocular entry and can be done in an office setting for some patients, though discomfort often necessitates an operating room environment. Building on the mechanism we just discussed, cyclodestruction has traditionally been reserved for eyes with poor visual potential. But in practice, many patients maintain reasonable vision afterward, so the role of these procedures has broadened. They're useful across essentially all glaucoma types, especially in elderly patients or those who aren't good candidates for incisional surgery because of systemic comorbidities. This approach is also helpful when patients cannot safely stop antiplatelet or anticoagulation therapy, since incisional surgery carries a higher bleeding risk. And for painful, blind, or nearly blind eyes, cyclodestruction remains one of the most effective ways to reduce pressure and improve comfort. There are a few cautions to keep in mind. The risk of sympathetic ophthalmia is small, but it's enough that we generally avoid treating eyes without light perception unless there's a compelling reason. Post-procedure discomfort can be significant, so steroids and cycloplegics are commonly used to improve pain control. For external cyclodestruction, we start with local anesthesia, retrobulbar, peribulbar, or subtenons. Many patients tolerate this well enough for the procedure to be done in the office, but that depends on their comfort with periocular injections. Transscleral CPC can be delivered in two main styles. One is with discrete treatment spots. It's straightforward, but because each pulse is concentrated, it can produce more collateral tissue injury. The other is broad sweeping application, where energy is deposited continuously as you move along the limbus. Sweeping tends to spread energy more evenly, but can be technically challenging, especially in tight or deep-set orbits. When we talk about external CPC, the technique really depends on whether you're delivering discrete pulses or using a continuous sweeping pattern. Discrete transscleral CPC uses the 810 nanometer diode laser through a fiber optic probe. You typically place 16 to 20 spots around 360 degrees, positioning the probe just posterior to the limbus to line up with the ciliary processes. The main technical pitfall is drifting into 3 or 9 o'clock, where the long posterior ciliary nerves run.
Continuous or micropulse CPC also uses an 810 nanometer diode laser, but the energy is delivered in a sweeping motion. Instead of individual burns, the laser cycles in a sinusoidal on-off pattern with about a 31% duty cycle. Settings vary depending on platform, but the principle is to spread energy more evenly while reducing thermal buildup.
The following videos demonstrate external cyclophotocoagulation. In the first video, the energy is delivered in a discrete fashion. Approximately 16 to 20 spots are applied adjacent to each other, avoiding 3 o'clock and 9 o'clock. The probe is held approximately 1/2 millimeter posterior to the limbus. The foot pedal is depressed for the duration of each energy delivery cycle. If a pop is heard, the energy is titrated downwards. Energy can also be delivered in a sweeping fashion. In the second video, energy is delivered continuously in a quadrant of the eye. Each 90-degree sweep takes about 40 seconds total, with each pass taking 10 seconds. Usually 3 to 4 quadrants are treated. Alternatively, 180-degree sweeps can be performed.
Now shifting from external techniques to internal cyclodestruction, endocyclophotocoagulation gives us a way to directly visualize the ciliary processes rather than treating through the sclera. Using an endoscopic probe placed into the ciliary sulcus, we can target the non-pigmented epithelium with much greater precision. Because this requires intraocular access, it's typically performed in the operating room, often combined with cataract surgery when the eye is already being entered. The basic technique begins with a clear corneal incision and deepening the anterior chamber with viscoelastic to widen the sulcus. A continuous wave diode laser, usually in the 0.2 to 0.5 watt range, is then applied directly to the ciliary processes. The goal is controlled whitening and shrinkage. Too much energy risks rupturing tissue and creating unnecessary inflammation. The laser is swept smoothly along the processes, treating roughly 270 to 360 degrees. Full 360-degree treatment normally requires a second incision for access. As with any laser-based procedure, the final effect depends on the selected energy level and the distance between the probe and the target.
CataractCoach.com, ECP, endoscopic cyclophotocoagulation. This is treating glaucoma at the time of cataract surgery by using a laser to cause cyclodestruction. So here's the patient, just had cataract surgery, eyes full of viscoelastic, IOLs going in the capsular bag, and now with the IOL in the capsular bag and the capsular bag and anterior chamber full of viscoelastic, we can get towards doing the ECP. Now, first thing is let's expand the sulcus. So some viscoelastic going in, use a cohesive agent, even a super cohesive agent would be good, just to give yourself more room there. So inflating the sulcus area. And there's the lens there, plenty of viscoelastic. Now, before we do this and get the laser ready, let me tell you that on CataractCoach.com, the website, do you know there's a free PDF book about cataract surgery? You can have it. There's a free 25-part curriculum series. There's our podcast. You can sign up for our daily email. A lot of good stuff. Here comes the laser. Now, the laser is not just a laser, it also has a camera and a light source. And so once you get this in there, you're going to try to ablate the ciliary processes. So the laser goes in the eye here. Nice if you can center up the camera a little bit. And the laser has an endoscope on it so you can actually see what you're doing. And you can control the laser delivery with a foot pedal. And your goal here is to ablate or basically damage cyclodestruction of the ciliary process so they make less aqueous. And so therefore you lower the pressure. So here you can see there's the view. Get the endoscope in a little bit more. And you need to find, that's the iris. So go underneath, there we go. Let's find the ciliary processes, there we go. Now you want to be about 2 millimeters away from the ciliary processes, and you can tell if you see 7, 8 of these ciliary processes in your view, you're too far away. If you can only see 2 or 3, you're probably too close. So probably aim to see, a few of them there. Now, when you deliver the laser energy, you're delivering it so that you cause this whitening here of the ciliary processes. And you want to go around as much as you can. From the main phaco incision, you could probably hit 270 degrees or so. Sometimes using a curved tip on the laser can give you a little more reach or access. You can also do it with two larger paracenteses, 180 degrees apart. So you can see there's the laser being delivered, and this is going to cause cyclodestruction, so it'll produce less aqueous, so you can lower the pressure. Now, you can also do this via pars plana approach if you're also doing a full pars plana vitrectomy at the same time, and that may even give you a little bit more advantageous angle. And you can imagine it's very hard to do this, and nearly impossible when the patient's phakic, trying to do it from the anterior like we're doing here. But a pseudophakic patient, at the time of cataract surgery, this is a very nice procedure. You can see staying about 2 millimeters away, and so delivering that energy, and you can titrate it. This is usually about 810 nanometer wavelength. And you can see once these are whitened like this, that's all you basically need to do. Now, there may be more post-op inflammation in these patients, so you may need to treat them with more corticosteroids, either topically or intracamerally for a little bit longer. But you can see now, that's a good view. There we go. So I like this picture-in-picture view, and that's very close to the processes. And once you've done it here, I think you're about 270 degrees worth, that should have a pretty good effect. Now, you can do full 360, but again, you probably want to make two a little bit larger paracenteses about 180 degrees apart from each other. And so you can see going to the subincisional area is very difficult. You got like a lot of torque there on the incision trying to get there, and that should really do it. So now the rest of the case can be finished, so we'll speed up the video here. And so at this point, of course, the rest of the surgery is routine. We're going to take out the viscoelastic from the eye, seal up the incisions. And again, a patient with a glaucoma, you probably do want to do, like it's shown here, do a monofocal lens. When you have a compromise of the optic nerve and the nerve fiber layer, a monofocal lens is probably your best friend here. And so sealing up the incision, nice looking rhexis too, beautifully centered lens. And looks like a single piece acrylic lens. And seal up the para. And again, you may want to put this patient on a little bit more steroids in the post-op period to help quell that inflammation. So in our complete library on Cataract Coach, now we have a video about ECP, endoscopic cyclophotocoagulation. And I got to remind you, the Cataract Coach website, so much good information there, the free Cataract Coach PDF book, curriculum series, our email of the day. Check out our podcast. We're all over social media, especially check out that Instagram, growing fast and very popular.
After cyclodestructive procedures, the post-operative course centers on controlling inflammation and managing discomfort. Topical or even subconjunctival steroids are often needed early on because these procedures can provoke significant ciliary body inflammation. Cycloplegic drops help as well. They reduce pain by relaxing the ciliary muscle, which is frequently irritated after treatment. Most patients should continue their existing ocular hypotensive medications initially. As the treatment effect becomes clearer and the eye settles, those can be tapered in a stepwise way. And because some patients experience deeper, more persistent pain, especially after transscleral techniques, oral analgesics, including narcotics when necessary, may be part of the initial management plan. Cyclodestructive procedures risk prolonged hypotony, which underlies many downstream issues like inflammation, pain, CME, and, in severe cases, retinal detachment or thesis. Sympathetic ophthalmia is rare but drives caution in NLP eyes. And with ECP, entering the globe adds a small risk of endophthalmitis not seen with external approaches. Cyclodestructive procedures, whether discrete, continuous, or endoscopic, consistently lower intraocular pressure. A randomized comparison of continuous versus discrete external CPC showed that both approaches achieve very similar pressure reduction, medication needs, and retreatment rates at 1.5 years. For ECP, the evidence isn't as strong. There's no randomized trial showing that combining it with cataract surgery outperforms cataract surgery alone, even though some observational work hints at added benefit. And across all forms, the effect tends to wane with time, so retreatments are common. As we shift from cyclodestructive procedures to angle closure management, the first major laser intervention to understand is the peripheral iridotomy. The goal here is straightforward: create a full-thickness opening in the peripheral iris to bypass pupillary block. By giving aqueous an alternate pathway into the anterior chamber, the pressure gradient that pushes the iris forward relaxes, allowing the angle to open if synechia haven't already formed. It's a simple anatomical change, but for angle closure disease, it's foundational.
When we talk about why an iridotomy works, we're really addressing the mechanics of pupillary block. In primary angle closure, the iris sits tightly against the lens. The iridolenticular contact increases, and that resistance traps aqueous behind the iris. As pressure builds posteriorly, the iris bows forward and crowds the angle. By creating that full-thickness channel, the iridotomy simply gives aqueous a shortcut into the anterior chamber. Once that posterior pressure dissipates, the iris relaxes backward and the angle widens again, assuming synechiae haven't already locked it closed. It's a straightforward pressure equalizing maneuver, but it completely changes the configuration of the chamber.
Now that we've outlined how an iridotomy relieves pupillary block, the indications fall into place. We use LPI anytime that block is the driver of iridotrabecular contact. That includes the full spectrum of primary angle closure disease, from an acute attack to primary angle closure to established primary angle closure glaucoma. It's also commonly offered to primary angle closure suspects, though the degree of long-term benefit in that group is still debated. When angle closure is secondary but still rooted in pupillary block, the same rationale applies. And in eyes with broad posterior synechia, a single opening may not be enough, so larger or multiple iridotomies can be required to meaningfully bypass the obstruction.
There are a few situations where an iridotomy either isn't safe or simply won't help. If the peripheral chamber is extremely shallow or flat, you're working right up against the endothelium, and the risk of corneal injury is too high. More importantly, LPI won't fix angle closure that isn't driven by pupillary block. Neovascular glaucoma and ice syndrome are classic examples. Here, the pathology is in the angle itself, so bypassing the pupil adds nothing. And once an eye has developed 360 degrees of synechioclosure, the damage is structural and permanent. Opening the iris won't reopen that angle.
For the iridotomy itself, the first requirement is a patient who can cooperate and maintain steady fixation so you can get a clear view of the peripheral iris. A second key step is lowering the intraocular pressure beforehand. Bringing the pressure down improves corneal clarity, reduces stromal edema, and gives you a much better view for targeting the iris. You can accomplish that with topical, oral, or intravenous hypotensive agents, with analgesics, or, when necessary, with a small paracentesis. In patients with a higher bleeding risk, such as those on anticoagulants or antiplatelets, pre-treating the iris with a green laser like argon can stiffen tissue and lessen the chance of bleeding when the full-thickness opening is created. I also like to give a topical pressure-lowering drop before the actual procedure to help prevent a postoperative pressure rise. Pilocarpine is then used to constrict the pupil and stretch the peripheral iris, making penetration more reliable. The caveat is that in prolonged acute angle closure, the sphincter can become ischemic and pilocarpine will be less effective. Once the eye is prepared, the iridotomy is performed using an Abraham lens with methylcellulose to stabilize the ocular surface and magnify the peripheral iris. The next key decision is choosing the location. I try to place the iridotomy as peripheral as possible, ideally in a spot where the iris is naturally thinner, such as an iris crypt, because those areas require less laser energy and tend to penetrate more predictably. Either a neodymium YAG laser or a green laser can be used. In cases with thicker or heavily pigmented irises, some surgeons like to pre-treat with a green laser to thin the tissue before switching to YAG for penetration. Once the iris gives way, you'll usually see a small release of fluid and pigment into the anterior chamber, which tells you the chamber has been entered. Transillumination can help you locate the opening afterward, but it doesn't guarantee that the iridotomy is actually patent, so you still need to assess fluid movement clinically. And finally, the opening has to be large enough to reliably relieve pupillary block. Sometimes enlarging a small iridotomy will help deepen the chamber and improve the angle profile. Now, shifting into postoperative care after a laser peripheral iridotomy, the immediate priority is to watch for early pressure spikes. That's why we check the IOP about half an hour to an hour after the procedure. Inflammation and a small amount of bleeding are common, so a short course of topical steroids for a week helps settle things down. If the pressure does climb, adding a topical hypotensive is straightforward. The follow-up window is intentionally broad because what we really care about is confirming patency and making sure the angle has actually deepened. And if the angle still looks narrow despite a patent iridotomy, that's a signal to dig deeper and reassess the underlying mechanism. When we talk about complications of an iridotomy, most of them stem from the same mechanisms we've already hinted at: mechanical disruption of tissue and postoperative inflammation. Bleeding and persistent irritation are the most common issues you'll see early on. With higher energy laser applications, there's always a theoretical risk of accelerating cataract formation or damaging the lens. The posterior segment isn't completely insulated either, and, although rare, retinal tears or significant pressure spikes can occur, along with endothelial injury at the corneal surface. The symptom patients often remember most, though, is dysphotopsia, glare, streaks, or halos created when light interacts with the tear meniscus at the site of the iridotomy. Some advocate placing the opening temporally to reduce awareness, but it's still unclear whether location truly changes the frequency of symptoms. In terms of efficacy, an iridotomy works well for classic pupillary block by deepening the angle, but it doesn't solve every mechanism. A noticeable subset still shows persistent closure despite a patent opening, which should prompt a broader evaluation. In primary angle closure, roughly half of patients still need medical or surgical pressure control. In acute attacks, the iridotomy helps stabilize things early on, but it underperforms compared with lens extraction for long-term IOP control. One study makes that clear. About 50% of patients treated with an iridotomy versus 3% after phaco still had elevated pressures at 18 months. And once chronic angle closure glaucoma is established, most patients require additional therapy. Progression risk also differs. Conversion from primary angle closure to chronic disease is relatively low, but those who present with acute attacks convert at a much higher rate, even with a patent iridotomy. The ZAP trial helps put all of this into perspective by looking specifically at primary angle closure suspects. Nearly 900 patients were randomized to iridotomy or observation. At 6 years, the observation group was more likely to show early signs of angle closure disease, 36 eyes versus 19 in the iridotomy arm. But even with that difference, the absolute conversion to primary angle closure or glaucoma was extremely low in both groups. There was no meaningful difference in acute attacks or in pressures above 24. Altogether, the data point to a fairly limited role for prophylactic iridotomy in suspects, especially when the baseline risk is already low. Given the limited preventative role of iridotomy in suspects, it's natural to look at other ways to modify the angle anatomy. Peripheral iridoplasty works through a very different mechanism. Instead of creating an opening in the iris, it uses a thermal laser, typically green or diode, directly on the peripheral iris stroma. The heat induces collagen contraction and stromothinning, and that contraction physically pulls the peripheral iris away from the trabecular meshwork. The net effect is a widening of the angle recess, which can be particularly useful when the iris configuration itself is the driver of crowding. With that mechanism in mind, the indications start to make sense. Iridoplasty is most useful when the angle remains narrow despite a patent iridotomy, which we see in a subset of primary angle closure suspects who simply don't open even after the block is relieved. It also has a role in acute angle closure when the chamber is too shallow to safely perform an iridotomy. Beyond that, it becomes the add-on strategy in situations where an iridotomy alone can't correct the anatomy. Plateau iris is the classic example, but the same logic applies in phacomorphic narrowing or in nanophthalmos, where even a patent iridotomy may not generate enough space. Evidence isn't robust in some of these anatomies, but clinical experience supports its use when mechanical crowding persists. Iridoplasty doesn't have many hard contraindications, but there are a couple of practical limitations worth keeping in mind. If you can't obtain a clear view of the peripheral iris, the precision needed for placing burns just isn't there. And because the laser spots are static, the patient has to be steady enough to tolerate the treatment safely. Beyond those relative cautions, most of the decision-making comes down to anatomy and whether the expected benefit justifies proceeding. The technique for iridoplasty is straightforward once the prerequisites are in place. Pilocarpine is given first to create meiosis and stretch the peripheral iris, which exposes the treatment area. A topical aqueous suppressant helps blunt any postoperative pressure rise. Because the burns need to be placed precisely, the patient has to maintain steady fixation, and the view of the peripheral iris must be clean. Most treatments involve 16 to 20 evenly spaced burns applied through a gonioscopy laser lens or an Abraham lens. The burns themselves are long and slow, allowing the thermal effect to contract stromal collagen. Energy and duration are titrated based on iris pigmentation and real-time tissue response, aiming for enough contraction to pull the iris away from the angle without overtreating. Postoperative care for iridoplasty mirrors the principles we've already seen with iridotomy. The pressure is checked about an hour after treatment to catch any early spikes, especially in eyes that were already crowded. A topical corticosteroid is then used to calm the expected inflammation and reduce discomfort. Beyond that, most patients recover smoothly, and the early pressure response helps guide whether additional therapy is needed. Complications from iridoplasty are generally uncommon, but they do reflect the fact that we're applying thermal energy directly to the peripheral iris. You can see anisocoria or subtle pupil distortion if the burns influence iris mechanics. Some patients experience prolonged inflammation, and in rare cases, the treatment can contribute to peripheral anterior synechia rather than relieving crowding. Localized iris discoloration is another benign but noticeable effect. Most of these issues are mild, but they're worth keeping in mind when deciding whether iridoplasty adds meaningful benefit for a given anatomy. When it comes to efficacy, iridoplasty occupies a very specific niche. In acute primary angle closure, when an iridotomy can't be performed, it provides short-term pressure control that's comparable to medical therapy. But whether it meaningfully prevents primary angle closure or chronic angle closure glaucoma remains uncertain. A randomized trial comparing iridotomy alone with iridotomy plus iridoplasty showed no difference in pressure at 1 year, though the combination group did develop fewer peripheral anterior synechiae. Another comparison with prostaglandin therapy found that prostaglandins achieved better pressure control at 1 year. In plateau iris, retrospective data suggests that the angle recess can remain more open over several years after iridoplasty, hinting at a possible role in slowing progression, but the evidence is still limited and mostly observational. Moving into incisional procedure, starting with trabeculectomy, the core idea is straightforward. The surgery creates a controlled fistula from the anterior chamber into the subconjunctival space, deliberately bypassing the eye's natural outflow pathway. The earliest versions were full thickness and unguarded, which predictably led to high rates of hypotony. That history is important because it explains why the modern operation evolved into a guarded procedure. Today, we use a partial thickness scleroflap to regulate flow. That flap adds resistance, allowing aqueous to leave the eye without collapsing the chamber. The guarded technique dramatically reduces hypotony risk while preserving the pressure-lowering effect, which is why it remains the benchmark for surgical filtration. The decision to move to trabeculectomy usually reflects the limits of everything that came before it. When a patient is already on maximally tolerated medications and has had appropriate laser treatments but still shows progression, filtration surgery becomes the next step. Even low IOP isn't reassuring if visual fields continue to worsen. Unchecked progression is the clearest indication. There are moments when we intervene earlier, such as when the fellow eye has severe glaucoma or when pressures are so high that medical therapy simply can't stabilize the situation. And occasionally, even without documented progression, the pressure may be clearly out of proportion to the stage of disease, and clinical judgment pushes us toward surgery before irreversible damage appears. There are also situations where trabeculectomy is either inappropriate or unlikely to succeed. An eye with no light perception is the clearest contraindication, largely because creating a fistula introduces a small but real risk of sympathetic ophthalmia to the seeing eye. Active neovascularization or uncontrolled anterior uveitis are relative contraindications. They need to be stabilized before filtration can be considered. Extensive conjunctival scarring from previous surgery or trauma lowers the odds of forming a functioning bleb, which makes success much less predictable. And eyes with extremely thin or abnormal sclera, whether from degenerative myopia or inflammatory disease, carry a higher risk of intraoperative and postoperative complications. All of these factors influence whether trabeculectomy is the right choice, or whether another approach would be safer and more effective. Even when trabeculectomy is technically feasible, certain patient factors make long-term success less likely. Diabetes, younger age, and African, Asian, or Hispanic ancestry are all associated with a more aggressive healing response, which tends to scar down filtration. Aphakic or pseudophakic eyes, especially those that underwent cataract surgery through a scleral tunnel, also carry higher failure rates. Secondary glaucomas with strong inflammatory components behave similarly, with rapid episcleral and subconjunctival fibrosis limiting bleb function. And, not surprisingly, a prior failed trabeculectomy signals a higher risk of failure the next time around. These factors don't absolutely preclude surgery, but they do shape expectations and may steer us toward alternative approaches. Before committing to trabeculectomy, there are a few preoperative steps that can meaningfully improve outcomes. Modern clear corneal cataract incisions, combined with intraoperative antifibrotics, have helped reduce scarring in pseudophakic eyes, which historically had poorer surgical success. Some surgeons also use a month of topical fluorometholone preoperatively to quiet surface and anterior segment inflammation, which may lower the postoperative steroid load. And just as important as the anatomy is the patient's ability to engage in follow-up. Trabeculectomy demands long-term postoperative care, with frequent visits and ongoing bleb management. If a patient cannot reliably participate in that process, the risk of failure or complications rises sharply. The first step in trabeculectomy is gaining stable exposure. Most surgeons achieve this by placing a partial thickness corneal traction suture superiorly, which gently rotates the globe downward and opens the surgical field. It's simple, predictable, and doesn't interfere with the conjunctiva you're about to work under. An alternative is a superior rectus bridle suture, but this comes with a trade-off. Manipulating the muscle risks postoperative inflammation or restriction, and several studies suggest it may actually lower the long-term success rate of the trabeculectomy. For that reason, it's used far less commonly in modern practice unless exposure is particularly challenging. Once exposure is secured, the next decision is the type of conjunctival incision.
Surgeons generally choose between a fornix-based or limbus-based flap. A fornix-based incision sits right at or just behind the limbus, giving excellent exposure and easy access to the surgical field. The trade-off is a higher risk of early wound leak, which is why meticulous closure is so important. A limbus-based incision starts farther back, about 8 to 10 millimeters posterior to the limbus. It tends to be more watertight in the early postoperative period and often produces a more diffuse bleb. The downside is that exposure can be less generous, so the choice comes down to surgeon preference and patient-specific anatomy. These illustrations reinforce the practical differences between the two conjunctival approaches. On the left, the fornix-based flap shows how the incision hugs the limbus, giving immediate access to the surgical field and allowing wide exposure once the tissue is reflected. On the right, the limbus-based design places the incision farther back, requiring more dissection but offering a more secure closure and often a more diffuse bleb postoperatively. The drawings highlight the direction of dissection through conjunctiva and tenons, while the clinical photograph shows how the incision is mobilized in real time. Together, the two approaches remind us that trabeculectomy technique is modular. Each step can be adapted to the anatomy and the surgeon's goals. Once the conjunctiva is reflected, the next step is fashioning the scleroflap. This flap is partial thickness and sits just posterior to the limbus, positioned so it can act as a controlled barrier over the sclerostomy. Its entire purpose is to regulate outflow, letting enough aqueous escape to lower pressure, but not so much that the chamber collapses. Centering the flap at 12 o'clock helps minimize later issues with bleb exposure and patient discomfort. Surgeons use different shapes, triangular, rectangular, trapezoidal, but the principle is the same. Create a stable, predictable guard that allows you to fine-tune flow later in the case. These images walk through the creation of the scleral flap in real time. You can see how the posterior edge is first outlined with a fine blade, establishing the depth and direction of the dissection. A crescent knife is then used to create the partial thickness tunnel, which is gradually opened laterally to form the flap. The final image shows the completed flap sitting flush and ready for the sclerostomy beneath it. The sequence highlights why this step is so central to trabeculectomy. The precision of the flap largely determines how controllable the aqueous outflow will be once the fistula is created. With the flap prepared, the next step is creating the actual fistula. A paracentesis is made first so you can control the chamber and reform it as needed during the rest of the case. Then a sharp blade is used to enter the anterior chamber beneath the scleral flap. Removing a small corneoscleral block opens a direct pathway for aqueous to exit into the subconjunctival space. Surgeons can create this opening freehand or with trephining instruments like a Kelly punch. Either approach works as long as the fistula is clean and well-centered. The flap must overlap the opening on all sides because it's the flap that ultimately meters the outflow and prevents postoperative hypotony. After the fistula is opened, an iridectomy is usually performed to keep the iris from billowing forward and blocking the outflow pathway. It's a small step, but it safeguards the entire operation. Some surgeons omit the iridectomy in carefully selected pseudophakic eyes where the risk of occlusion is low, but that choice requires confidence in the anatomy and the stability of the anterior chamber. Ultimately, it's a balance. Performing the iridectomy adds a bit of bleeding and inflammation, while skipping it raises the possibility of the fistula plugging off. The decision hinges on the specific eye in front of you and the surgeon's threshold for postoperative risk. Here is a figure depicting the steps we discussed in the last slide. At this stage, the goal is to establish a controlled outflow pathway and ensure it stays open. The fistula is created first. You can see the punch sliding under the scleral flap and engaging the posterior lip of the anterior chamber.
Removing that corneoscleral block establishes a direct conduit into the subconjunctival space. Once the fistula is in place, a peripheral iridectomy is fashioned to keep the iris from sealing off the opening. The cut has to be deliberate, large enough to prevent occlusion, but not so large that it increases bleeding or postoperative inflammation. Together, these two steps turn the scleral flap into a regulated outflow system, and they're the point where even small technical choices can dramatically affect long-term blood function.
Once the fistula and iridectomy are completed, the focus shifts to controlled closure. The scleral flap is secured with fine nylon sutures, and the tension on each suture becomes the main regulator of aqueous outflow. Some surgeons pre-place their sutures to streamline the process, while others incorporate releasable sutures to allow post-operative adjustment without returning to the laser. After the flap is tied, the anterior chamber is reformed and the outflow rate is titrated by adjusting flap tension. The goal is a watertight closure. Any leak at this stage increases the risk of hypotony and early complications. Final steps vary slightly depending on whether the flap is limbus-spaced or fornix-spaced, but in both approaches, meticulous conjunctival closure is essential for long-term bleb health.
Here is another figure depicting the last two steps of this surgery. This step focuses on securing the scleral flap and establishing controlled outflow. The flap is typically closed fairly tightly, especially when mitomycin C is used, so spontaneous drainage stays minimal. Surgeons may choose releasable sutures, which can be adjusted or removed postoperatively, or interrupted sutures that can later be cut at the slit lamp. Once the flap is secured, the outflow is checked at the end of closure, often using a sponge or fluorescein to confirm adequate but not excessive egress. The goal here is the same across techniques: a stable flap, a predictable flow rate, and a watertight conjunctival seal that supports long-term bleb function.
There are multiple ways to tie a releasable suture across a trabeculectomy flap. The releasable suture is advantageous because it can be removed at the slit lamp with a simple blade and forceps. No expensive laser is required, and no contact lens needs to be placed on a tender postoperative eye. In this case, 10-0 nylon sutures are placed at each flap corner. These sutures are not releasable. These will have to be lysed with the laser postoperatively if additional flow is needed. After topping off the anterior chamber with BSS, excessive flow is seen at the nasal gutter. A releasable suture will be placed across this gutter to decrease flow and to prevent an early wound leak. The releasable suture is started by driving the 10-0 needle across the limbus starting in cornea. Starting in cornea will allow the knot to be accessible postoperatively. Then the needle is driven across the flap and back out across the gutter. Finally, it is passed across the limbus again to end in cornea, where a knot can be tightly tied to close off flow. This suture can be released postoperatively by cutting it and then pulling it out. Once the releasable suture is finalized, the conjunctiva can be closed. Each step of a trabeculectomy can be performed in a variety of ways. The first step is to create a conjunctival flap. In this case, a fornix-based flap is initiated by creating a superior peritomy with a blade. Likewise, scissors can be used. Some surgeons prefer a limbus-based flap, which is started 10 mm posterior to the limbus. Next, bare sclera should be exposed. Tenon's insertion is being snipped with sharp scissors here. This allows insertion of a muscle hook to bluntly dissect a pocket under conjunctiva and Tenon's layer. This pocket is important as it creates space for mitomycin C-soaked pledgets. Mitomycin C decreases fibrosis and increases surgical success. The next step is to create a trabeculectomy flap. It is outlined and then dissected forward into clear cornea at 1/2 to 3/4 scleral depth. Pledgets soaked in mitomycin C are placed on the superior sclera beneath conjunctiva and Tenon's layer. While the mitomycin C is given time to absorb, 9/0 nylon anchor sutures are placed at the nasal and temporal edges of the peritomy in anticipation of a running closure. The pledgets are removed after a pre-specified time of exposure, and mitomycin C is rinsed away. The anterior chamber is entered at the flap fornix. A trabeculectomy opening is fashioned. The trabeculectomy can be achieved in a variety of ways with different instruments. In the vast majority of cases, an iridectomy is created to prevent iris prolapse from plugging the trabeculectomy opening. Next, the flap is reapproximated to its bed with 10/0 nylon suture tied just tightly enough to create resistance to outflow without totally preventing flow. The last major step of trabeculectomy is conjunctival closure. Whatever technique is used for closure, it should be watertight, as early leaks can lead to failure. A running closure is used to achieve this goal in this case. 9/0 nylon on a VAS 100-4 needle is critical for this type of closure. The knot of the previously placed anchor suture is buried under conjunctiva to prevent irritation to the patient. The VAS 100-4 needle is passed through conjunctiva and cornea in an alternating fashion to both stretch and crimp the conjunctiva against the limbus. After coming out on top of the conjunctiva, a long suture pass of several millimeters is made through cornea. The needle is then driven through conjunctiva, starting at a point behind the last corneal exit point. A long pass is made over conjunctiva before piercing it again. The second corneal pass is again long and begins behind the last conjunctival exit. As well, it is very close to the first corneal pass. As one can see, the technique pulls conjunctiva tightly against the limbus. All suture bites are larger than the space between bites. Before finalizing the final knot, by tying it to the remaining anchoring suture, excess slack is pulled out of the running suture. The end result is a great bleb and a watertight closure.
Here is another figure depicting the last two steps of this surgery. This step focuses on securing the scleral flap and establishing controlled outflow. The flap is typically closed fairly tightly, especially when mitomycin C is used, so spontaneous drainage stays minimal. Surgeons may choose releasable sutures, which can be adjusted or removed postoperatively, or interrupted sutures that can later be cut at the slit lamp. Once the flap is secured, the outflow is checked at the end of closure, often using a sponge or fluorescein to confirm adequate but not excessive egress. The goal here is the same across techniques: a stable flap, a predictable flow rate, and a watertight conjunctival seal that supports long-term bleb function.
5-FU is a pyrimidine analog that inhibits thymidylate synthetase, blocking DNA synthesis and slowing fibroblast proliferation. It can be applied intraoperatively on sponges or used postoperatively as a subconjunctival injection when additional antifibrotic effect is needed. Its major limitation is corneal epithelial toxicity, so caution is essential in eyes with significant ocular surface disease. Mitomycin C is a naturally occurring compound with both anti-neoplastic and antibiotic properties. As an alkylating agent, it cross-links DNA, blocking cellular replication and triggering apoptosis. It is particularly cytotoxic to fibroblasts and vascular endothelial cells, which reduces fibroproliferation and angiogenesis during wound healing. MMC can be delivered on soaked sponges or by subconjunctival injection, and injections may produce more diffuse blebs. Because the drug is highly toxic, any intracameral exposure must be strictly avoided. A Cochrane review found that trabeculectomy paired with mitomycin C achieved lower intraocular pressures at 1 year compared with cases using 5-FU. Despite this difference in pressure control, the visual outcomes between the two groups were essentially the same. Diffuse blebs spread broadly under the conjunctiva, elevating smoothly with minimal focal scarring. They're generally associated with healthier outflow and lower risk of failure. Localized blebs are focal, higher, and often surrounded by tighter conjunctival scarring. These features can signal more restricted flow and a higher likelihood of bleb-related problems. In the postoperative period, the bleb is vulnerable, and a range of early and late complications can shift the trajectory of the surgery. Early on, hypotony and its downstream effects, maculopathy, choroidal effusion, even suprachoroidal hemorrhage are among the most vision-threatening issues. Wound leaks, a shallow chamber, or aqueous misdirection can also destabilize the eye, and each requires rapid identification because the window to reverse damage is small. Infection can appear early or late, but blebitis and endophthalmitis are particularly associated with thin, avascular blebs and remain one of the most feared long-term risks. Over time, we also see more chronic structural changes, cataract progression, bleb failure or overfiltration, ptosis, and symptomatic blebs that affect quality of life even when pressure control is good. The point is that trabeculectomy doesn't end in the OR. Success hinges on recognizing these complications early and intervening before they compromise vision or the bleb's longevity. Overfiltration is fundamentally a resistance problem. When the flap isn't providing enough counterpressure, aqueous exits too freely and floods the subconjunctival space. The usual culprits are mechanical: sutures that are too loose, a buttonhole in the flap, or a fistula placed too close to the flap margin where the flap can't adequately modulate flow. Clinically, you'll see an exuberant, elevated bleb without any evidence of a leak, and very often a shallow anterior chamber, because the eye simply can't maintain volume. The risk here isn't just transient hypotony. Prolonged overfiltration can distort the posterior pole, leading to hypotony maculopathy with radial folds and visual distortion. That's the milestone that forces intervention. Management works by restoring resistance. Reducing topical steroids encourages fibrosis and stiffening of the tissue. And if that's not enough, adding sutures to the flap, either at the slit lamp or in the OR, can reliably slow flow. The threshold to act is low when the macula is involved because hypotony maculopathy can become permanent if it's allowed to persist.
If a patient is noted to have overfiltration after trabeculectomy, a transconjunctival suture can be placed at the slit lamp to limit flow. The flap is identified, and a 10-0 nylon suture is used to close the flap. Care must be taken to have comfortable hand positioning. If this maneuver is unsuccessful in limiting flow, the patient can be taken back to the operating room for a more extensive revision.
Bleb leaks can occur early or late after trabeculectomy, and the timing often gives you a clue to the underlying problem. Early leaks almost always originate at the incision site, typically an unrecognized buttonhole made during conjunctival dissection or erosion directly over a flap suture. Patients usually complain of excessive tearing or irritation, but clinically what matters is confirming the leak with a Seidel test. On exam, these eyes often show hypotony, a shallow or normal anterior chamber depending on the degree of leakage, and a low-lying bleb because the fluid simply can't accumulate. Left untreated, leaks drive two major complications: accelerated fibrosis that can shut the bleb down, and infection. The infection risk is not trivial. These thin, avascular blebs are the classic setup for infection. Management aims to promote sealing and reduce flow through the fistula. Reducing topical steroids encourages conjunctival fibrosis, while aqueous suppressants lower the transbleb pressure gradient and help the epithelium heal. An oversized bandage contact lens can be surprisingly effective. It provides a scaffold for reepithelialization and can tamponade the leak mechanically. If conservative measures fail or the leak is persistent, suturing the site is the next step.
Using fluorescein, the location of a bleb leak can be easily identified. To identify a bleb leak, fluorescein is applied to the bleb. Egress of aqueous displaces the fluorescein, identifying the location and briskness of the leak.
Choroidal effusions are one of the classic signs that postoperative IOP has dipped too low at any point after surgery. They're especially common in older patients whose sclera is more rigid and less capable of buffering pressure changes. Clinically, the anterior chamber often looks shallow, usually more peripherally than centrally, and the fundus exam shows those characteristic gray dome-shaped elevations over the vortex vein regions. Management depends entirely on the underlying mechanism. Cycloplegics are always useful because they rotate the ciliary body posteriorly and help deepen the chamber. If the effusion is driven by overfiltration or a bleb leak, the priority is reducing steroids to promote conjunctival fibrosis and tighten up the system. But if the root problem is ciliary body inflammation or decreased aqueous production, then you do the opposite: increase steroids to restore secretion and reestablish pressure. A viscoelastic injection into the anterior chamber is a mechanical way to temporarily raise IOP and often speeds recovery. If the effusions are large, kissing, or simply not improving, posterior sclerotomies can be performed to drain them. And if the problem originates from an uncontrolled flap, reinforcing the scleral flap at the same time may be necessary to prevent recurrence.
Persistent choroidal effusions due to increased flow after trabeculectomy may require flap resuturing and choroidal drainage. The conjunctiva is incised, and dissection over the flap is done carefully. It is useful to attain maximum exposure by lysing adhesions and creating a wide peritomy. A traction suture can also be useful to achieve maximum exposure. Tenonylon sutures are used to secure the trabeculectomy flap into place after adequate exposure has been achieved. Several sutures may be required to achieve the desired effect. After the flap is sutured down appropriately, attention is paid to the choroidal drainage. The sclera is marked 3 mm posterior to the limbus, and a perpendicular incision is made in the sclera. When a full thickness incision occurs, yellowish fluid will egress, confirming that the incision is in the proper location. A small block of sclera can be removed to help with drainage. Pressurizing the anterior chamber also enhances drainage of choroidal fluid. When closing, the scleral incision is left open for further drainage to occur.
Sclerostomy obstruction is the most common early postoperative cause of trabeculectomy failure. The clinical picture is classic. The bleb is low or flat, the anterior chamber is nicely deep, and the IOP is high. That combination should always make you think about something physically blocking the sclerostomy rather than overfiltration or leak. The obstructing material can be a blood clot, fibrin, vitreous, or the iris itself. Gonioscopy is crucial because it's the only way to definitively identify what's filling the ostium. Iris incarceration is a big one. Look for a peaked pupil or the iris pulled toward the flap, and remember that these patients often present with pain and pressure spikes. Management depends on the culprit. If the iris is involved, laser iridoplasty, or small peripheral iridotomy, can free it from the ostium and re-establish flow. If a clot is the problem, tissue plasminogen activator can rapidly lyse it and reopen the fistula. Fibrin plugs may respond to steroids or TPA as well. Vitreous obstruction is less common and usually indicates a zonular or capsular issue, sometimes requiring anterior vitrectomy. The key is early recognition. The longer the blockage sits, the higher the risk of scarring at the flap and long-term failure of the bleb. Tight scleroflap sutures are one of the most common reasons for inadequate early flow after trabeculectomy. When the sutures are too tight, outflow is restricted, and you see the classic triad: a low or flat bleb, a deep anterior chamber, and an IOP that's higher than the target. One quick maneuver you can use in clinic is digital ocular massage. By gently increasing posterior pressure, you can force a bit of aqueous through the flap, raise the bleb, and transiently lower the IOP. If the bleb elevates with massage, that's an excellent sign. It tells you the flap is functional and that the resistance is primarily suture-related rather than due to scarring or obstruction. The bigger decision is when to cut sutures. Timing here is everything. If you cut too early, before the flap has stabilized and before the eye has formed enough subconjunctival fibrosis, the risk is overfiltration and hypotony. But if you wait too long, fibrosis develops under the flap, permanently reducing outflow capacity and compromising long-term pressure control. So you're always walking a line. Adjust early enough to restore physiologic flow, but not so early that you destabilize the bleb. When scleral flap sutures are too tight, we see the classic postoperative picture shown here. In image A, the bleb is low and relatively flat because very little aqueous is making it through the flap. So despite a functioning fistula, the outflow resistance is simply too high. The anterior chamber is typically deep in these situations, and the IOP often remains above target. Image B highlights how we can use a laser gonial lens to directly visualize the flap sutures. This becomes important when we're considering laser suture lysis. The key is identifying which suture is contributing most to the resistance, usually the most anterior or tightest appearing one. Then in image C, you see the immediate effect of successful suture lysis. Once a suture is cut with a green laser, aqueous begins flowing more freely, and the bleb elevates fairly quickly. That rapid change is what you hope to see. It confirms that the resistance was indeed mechanical and not due to scarring under the flap. This sequence really illustrates how dynamic trabeculectomy management is. The operation doesn't end in the OR. The follow-up period is when we fine-tune outflow by adjusting sutures. And small maneuvers like laser lysis can entirely change the trajectory of the bleb. When a post-trab patient presents with a markedly shallow anterior chamber and a reasonably formed bleb, the two diagnoses that should immediately come to mind are malignant glaucoma and suprachoroidal hemorrhage. Early on, they can look almost identical. Both may show a shallow or flat chamber, often extremely shallow centrally, along with a moderate to large bleb and normal or elevated IOP, so neither the bleb nor the pressure reliably distinguishes them. Because the anterior segment findings overlap so much, the real discriminator is the posterior segment. A fundus exam, or a B-scan if the view is limited, is usually required to tell whether you're dealing with choroidal expansion or hemorrhage or malignant forward rotation of the lens iris diaphragm. Suprachoroidal hemorrhage has a very characteristic appearance: gray, dome-shaped elevations deep in the fundus, typically anchored at the vortex vein regions. When you see these broad, immobile gray choroidal domes, the diagnosis is usually straightforward. Management is mostly supportive in the acute phase. The priorities are pain control and temporizing IOP management to stabilize the eye while the hemorrhage organizes. If the patient is on anticoagulants or antiplatelets, stopping them, when medically safe, can help limit expansion. Importantly, drainage is not done immediately. We typically wait several days for the blood to clot and liquefy unless there is a compelling reason to intervene early. Those exceptions are rare but important: corneal lenticular touch, intractable pain, or kissing choroidals threatening permanent structural damage. The overall guiding principle is stabilization first, drainage only when the anatomy or symptoms force your hand. Malignant glaucoma is all about aqueous being misdirected posteriorly into or behind the vitreous, which pushes the lens iris diaphragm forward and collapses the anterior chamber. So the treatment strategy is really aimed at reversing that misdirection. We start with cycloplegics because pulling the ciliary body backward helps reopen the anterior chamber and redirect aqueous anteriorly. At the same time, we use medical IOP-lowering therapy just to stabilize the pressure while we try to break the misdirection. Next, we attempt to disrupt the anterior hyaloid face with ND-YAG laser. In pseudophakic eyes, you can go right through the pupil. In phakic eyes, you may need to work through a peripheral iridotomy to get access. If the hyaloid face opens, the pressure gradient equalizes and the chamber usually deepens quickly. But if laser attempts fail, the definitive step is a vitrectomy, and the key is aggressively addressing the anterior hyaloid. That's the structure driving the pathology. Once that barrier is removed, aqueous flows forward again and the anterior chamber reforms. These photos illustrate the classic postoperative presentation of malignant glaucoma. In image A, you can see the hallmark feature, a flat or extremely shallow central anterior chamber despite the fact that the wound is closed and the bleb is functioning. That immediately tells you the problem isn't overfiltration. Image B highlights something important but often overlooked. The fellow eye also has a naturally shallow chamber, which is a major risk factor. Eyes with crowded anterior segments are far more prone to aqueous misdirection after surgery. Then, in image C, even though the chamber is flat, the bleb is elevated, confirming that aqueous is indeed flowing outward through the trabeculectomy site. The filtering mechanism is working, so the reason the chamber is flat must be internal misdirection of aqueous into the vitreous compartment, not external leakage or excessive filtration. Together, these images show the classic triad: flat anterior chamber, functioning bleb, no posterior pathology on B-scan, which is exactly the scenario where malignant glaucoma must be suspected. Fibrosis is the primary long-term cause of trabeculectomy failure. It most often occurs in the subconjunctival space, but scarring at the scleral flap can also shut down outflow. The key concept is that adequate early postoperative flow is protective. If flow is low early on, the eye interprets the site as a wound to be sealed. Prevention relies on topical steroids and, when needed, MMC or 5-FU. Early conjunctival hyperemia over the bleb is a warning sign of escalating fibrosis and should prompt steroid or antifibrotic adjustment. If flow is borderline, you can increase it by cutting or removing scleral flap sutures, which reduces the risk of scarring. Once fibrosis is established, bleb needling becomes the main intervention, using a sharp needle to free adhesions and recreate a more diffuse bleb that resists rescarring.
Bleb needling revision can be an extremely effective way to resurrect a failing filtration bleb either in the early postoperative period or even years later. For late bleb revisions, I use mitomycin C 0.1 milligram per ml concentration and inject 0.1 ml subconjunctivally about 30 minutes before I do the procedure. It's important to use the proper instrument for the actual needling procedure, and I prefer the stiletto blade. It's an MVR blade from BD, and it's rigid. It has a very sharp tip, a long, skinny shaft that does not create a big opening in the conjunctiva. After the patient is prepped with the lid speculum, betadine, or antibiotics, and several doses of tetracaine, you start the procedure by incising very far peripherally as much as you can, and then slowly moving the blade towards the area of resistance. The area of resistance can vary from patient to patient. It might be a tenon cyst, or it might be, in this situation, the resistance seems to be right beneath the posterior exit of the scleral flap. Once you find the area of resistance and enter that area, it's important to sweep rather than simply puncture the area. A puncture will seal very quickly over the next few days, whereas if you make a big enough opening in the area of fibrosis, it's likely to remain patent. As you can see here, once I lift that scleral flap and enter beneath that fibrosis, the bleb elevates beautifully. It's unusual to need to do anything to the entry site, as oftentimes tenons will come and plug the opening.
Bleb-related infection is one of the most feared late complications of trabeculectomy, occurring in roughly 1.5 to 6% of patients. Even mild symptoms like tearing, irritation, or blurred vision need to be taken seriously because the progression from blebitis to endophthalmitis can be rapid. Several risk factors significantly raise concern. Blepharitis is a major one. An unstable lid margin seeds bacteria directly onto the bleb. Inferior blebs sit in the tear lake and are exposed to more bacterial load. Bleb leaks dramatically increase the risk by providing a direct pathway into the eye. And thin-walled blebs, especially those created with high-dose MMC or 5-FU, are structurally fragile and more prone to leak or become infected. Risk reduction centers on good surgical planning and post-operative management. A fornix-based trabeculectomy facilitates better healing and reduces bleb irregularities. And the diffuse application of antifibrotic agents helps avoid creating the thin, avascular blebs that carry the highest infection risk. These images highlight the spectrum of bleb infections. On the left, we're looking at blebitis. You can see a mucopurulent infiltrate sitting within the bleb itself, with localized conjunctival hyperemia but relatively little anterior chamber reaction. Vision may still be fairly preserved at this stage, and the infection is largely confined to the bleb. On the right is bleb-related endophthalmitis, which is a completely different level of severity. Here, the conjunctival injection is diffuse. The bleb is filled with purulent material, and now the anterior chamber shows a marked inflammatory reaction, sometimes even a hypopion. This represents intraocular infection, not just surface involvement, and demands immediate aggressive treatment. These images are a good reminder that subtle blebitis can deteriorate rapidly, and early recognition is critical to preventing progression to vision-threatening endophthalmitis. Bleb infections fall along a continuum, and this staging system helps us decide how aggressively to intervene. Stage 1 is limited to the bleb itself, erythema around the bleb, and an infiltrate without intraocular involvement. Stage 2 adds anterior chamber inflammation, meaning the infection is no longer purely superficial. Stage 3 is where things become dangerous, a hypopion or any intravitreal extension. These late-onset cases are often due to highly virulent organisms like Streptococcus or gram-negative bacteria, and this is essentially bleb-related endophthalmitis. For stages 1 and 2, we treat as blebitis, topical fluoroquinolones, and escalate to fortified topical or even subconjunctival antibiotics if needed. Prognosis here is generally good if treatment is initiated promptly. Stage 3 requires immediate intravitreal therapy, either a vitreous tap with intravitreal antibiotics or a primary vitrectomy depending on the clinical situation. Visual outcomes at this stage are significantly worse, and early recognition is key to preventing progression.
When evaluating a postoperative trabeculectomy, the first branch point is simply the intraocular pressure. If the IOP is low, the next question is whether the bleb is elevated. If the bleb is flat or barely elevated, think aqueous hyposecretion, a bleb leak, or choroidal effusion, all causes of low flow entering the subconjunctival space. If the bleb is elevated with low IOP, that's classic overfiltration, where resistance under the flap is too low. If the IOP is high, we again ask whether the bleb is elevated. A flat or poorly formed bleb suggests an outflow obstruction at the flap, ostomy obstruction, tight flap sutures, or early flap fibrosis. If the bleb is elevated despite high pressure, then anterior chamber depth becomes the key discriminator. A shallow chamber points towards suprachoroidal hemorrhage or malignant glaucoma, both of which push the chamber forward while maintaining or elevating IOP. A deep chamber with high IOP and an elevated bleb means we look at bleb morphology. A localized cystic bleb suggests a tenon cyst, while a diffuse bleb with high pressure usually reflects increased flap resistance, essentially an early failure of controlled filtration.
This algorithm helps you rapidly categorize post-operative problems into mechanical obstruction, overfiltration, wound healing issues, or rare posterior processes, guiding targeted intervention instead of trial and error. Thanks for watching. In the next video, we'll finish the remaining topics in surgical management of glaucoma and complete the chapter.